A great pleasure to be here. It's always interesting and fun to interact with new audiences and get to hear people's experiences around mental health and also understand the work that they are doing within this space or related spaces. I think I've got an hour today to talk about global mental health. I'm going to do a very overarching, high-level overview of global mental health and its history and where we are going. But broadly, what I'm going to kind of focus on is why are we where we are at? Like what is the issue that we are trying to tackle? What are the things that we have done historically to tackle these problems within the global mental health space? And what is or was wrong with these ways of tackling these problems? What are we trying to do differently now to kind of resolve some of these issues? And finally end with a little bit of speculation slash recommendations on what we could do moving forwards to kind of solve this wicked problem. So that's the kind of broadly the agenda of today's session. But before I do that, I would like to take a step back and kind of just allow ourselves to reflect on what do we mean by global mental health, right? And this is the definition, and there are multiple definitions, and this is one that I like best. I'm not going to read out all of this. I'm going to leave this slide on, but just to say that global mental health is basically the application of global health and or public health principles to the space of mental health. This is quite different from psychiatry as we know it or psychology as we know it at an individual level. We are looking at this from a level of populations, what we can do to prevent, promote, treat, rehabilitate populations or large chunks of people as against individual level care, but also doing all of this on a very strong foundation of health equity and human rights. And there is a history behind why these become the foundational principles of global mental health, as we know that the history of mental health care and psychiatry has been replete with examples of how human rights of people with mental health problems have been violated across most parts of the world over the years. So that's why this becomes very important, the last bit of it, mental health equity and human rights. So just to again give you a sense of how global mental health field has progressed over the years, because it's a relatively newer field. I mean, people have been talking about psychiatry, psychology, etc., but talking about global mental health is slightly more recent in the larger scheme of things when it comes to global health. And this is just one metric of to show how the field has progressed over the years, right? So this is a sense of the number of publications that mention the word global mental health or are in the field of global mental health. And as you will see from 2007 to 2024, there's been an exponential increase in the number of publications that have been written on the topic of global mental health or research that has been done on the topic of global mental health. So that in itself is a very strong indicator of a field that is growing in prominence. And why is it a priority? Why do we need to be thinking about mental health at a global level, at a public health level, at a global health level? There are several reasons, and I'm sure none of this is new to you, but it bears repeating because it's so important. So one is the high prevalence rates, right? Both in terms of the proportion of people with mental health problems and the absolute number of people with mental health problems. It's a huge number across the world. The other thing is the disability and mortality that is caused by mental health problems, and I'll elaborate a little bit more on it in the upcoming slides. But mental health problems across the world, regardless of which country you are in, are contributors to major amounts of disability as well as mortality. The other important thing to remember is that mental health problems do not just affect the person with mental health problems, but has impacts on people around them. Be it families, be it children, because there's intergenerational transfer of the effects of mental health problems, and societies at large in terms of the costs that it causes. And then finally, for those of you who kind of are more focused on physical health, it's very important to remember that the slogan, no health without mental health, is not just a slogan, it's reality. Because for a large chunk of people with physical health conditions, especially chronic physical health conditions and non-communicable diseases, there is a huge comorbidity of mental health problems which have an impact on the outcomes for the non-communicable diseases. So let's kind of look at this in slightly more detail. What do I mean by saying that morbidity, mortality, and costs are very high? Again, let's not focus on the numbers. The numbers are very big, but let's just look at the principle of this, right? Whichever way you cut it, whatever metric you use, right? Disability adjusted life years or years lived with disability, whether you want to look at the absolute number of DALYs or disability adjusted life years, or whether you want to look at the proportion of disability adjusted life years of all the health condition and what proportion of that is attributed to mental health problems, whatever metric you might use, you realize that mental health problems are a huge contributor to disability across the world. So it doesn't matter what metric you use. It is a stated and known fact that it is a huge contributor to morbidity and disability. And this is not reducing, right? It's not just about what is happening at the moment. Year on year, if you look at this slide here, year on year, the burden of disease because of disability, because of mental health problems has been increasing. And this is not just in some parts of the world or the developing world or only the developed world. It's across the world. If you look at these different worms that are going up in these slides, you will see that the disability caused due to mental health problems has been increasing and will continue to increase. There's no reason to believe that it will reduce unless we have good systems in place to intervene for people with having mental health problems. Let's just look at mortality, because for some people, disability or morbidity is not a very hard indicator. There can't be any hard indicator than death, right? Mortality is the hardest indicator one can think about as an adverse outcome of any kind of a health problem. And let's just think in terms of two things. One is, we know for sure that people with mental health problems have a shorter lifespan as compared to people who do not have mental health problems. For various reasons, people with mental health problems on an average live 12 years less than those who do not have mental health problems. And the reasons are as varied as the lifestyle that happens with mental health problems, some common genetic factors which relate to increased mortality as well as mental health problems, the side effects of medications that get prescribed for mental health problems. So there are various reasons in addition to people dying by suicide. But if you want to really put a number to this, and you might be wondering why I have this picture of a plane crash in there. If you want to put a number to this, imagine 62 air crashes happening every day of the year for the next 365 days, right? That is the number of people that die from mental health problems. And just imagine a world in which 62 air crashes are happening every day, right? Are really happening every day. Do you think people would sit quietly and just see it happen? No, there would be a huge furor. But the same number of people are dying because of mental health problems. And do you even hear a peep from policymakers? So that's the kind of the extent of the problem in terms of mortality. And lastly, let's look at, for those of you who think in terms of money and economics and costs, let's just think in terms of the economic costs of mental health problems, okay? These are three of the top companies in the world in terms of the prices of shares. The economic costs of mental health problems, if I were to take the economic cost of mental health problems in a year, I could buy these three companies flat out and still have millions of money spare, US dollars spare. The amount that it would cost me to buy these three companies would be $1 trillion. And year on year, we are losing $5 trillion due to mental health problems. As much as I don't like putting a cost to people's suffering and disability, sometimes we need to put these numbers out to convince policymakers about the importance of doing this, right? And comorbidity, again, disability, mortality, costs, and comorbidity. Is a bidirectional relationship of a range of, this is just showing depression, but a range of mental health problems with a very different kinds of non-communicable diseases like diabetes, hypertension, as well as communicable diseases like HIV, tuberculosis, etc. Okay, so there's this double burden of physical health problems and mental health problems in different kinds of relationships that we have shown here. So one would ask, if we've known this for so long, what have we been doing? As a field, as people working in the global mental health space, what have we been doing? I mean, it's easy to state problems, isn't it? I mean, it's very easy to come and say, these are the problems. Anyone can do that. Well, what are we trying to do about it? I think that's the big question. And some of the things that we have been trying to do have not been very useful. For those of you who do not know this gentleman here, Dr. Thomas Insel, is at one point in time, he was the boss of the NIMH, National Institute of Mental Health in the US. He was a big one on looking at or trying to find out the biological reasons of mental health problems. So when he was leading the NIH, spent billions of US dollars on trying to find out the causes of what leads to mental health problems, the biological underpinnings of mental health problems. And at the end of it, didn't find anything new that we already didn't know. And so when he retired, he kind of accepted that he shouldn't have done this. But by then it was too late. The money was already gone. And this statement in there is an actual statement that was made by a caregiver of a person with severe mental disorders at a talk that Tom Insel was giving. And that caregiver made this exact statement out there. And what is this chemistry of the paint that person is talking about? The chemistry of the paint is the things that Tom Insel put the money in, which is trying to find the biological underpinnings of mental health problems when we should have been trying to solve the real problem, which is putting out the fire. And what is this fire that we are talking about? The fire that we are talking about is this. Okay. The fire that we are talking about is the proportion of people with mental health problems who do not have access to care for mental health problems. Whether we look at it globally, as you will see on the figure where the graph is green, or you look at it by countries, as you will see on the figure on the right, the blue figure graphs, which is from India. You look at developed countries, you look at developing countries. What we know is that a worryingly large proportion of people with mental health problems do not have access to any kind of mental health care. And here, I am not talking about high quality evidence-based mental health care. I'm just talking about some kind of contact with some kind of health services which will provide you with some kind of intervention. What we call as contact coverage. And you will see here that anywhere between 6 to 9 people, depending on what kind of condition it is, which country you're talking about, out of every 10 people with mental health problems, 6 to 9 of them will not have access to any kind of service. Or you twist that around and say, only 1 to 4 people with mental health problems will have access to some kind of service. And that's the fire that we've been talking about. Right, that we have been trying to. And one would think that with the arguments that are made, that it's such a big problem, that it's affecting people in so many different ways, and the fact that we know what we can do about it, because there are evidence-based interventions which can be delivered, which are both biological, psychological, and social, for which there's substantial evidence, as you will see from the disease control priorities series for mental health problems. One would think that we know the problem, we have the solutions, probably we are not doing it because it's expensive. But the reality is it's not expensive as well. As you can see from this slide, per capita cost for scaling up an intervention for mental health problems is not that great in the bigger scheme of things. So, problem is big. Solutions are there. Solutions are not very expensive, but still, people do not have access to them. And why is that the case? Why are these solutions not reaching people? There are various reasons. There are various barriers to this not happening? There are demand side barriers and there are supply side barriers. So demand side barriers are things such as stigma, lack of awareness, which stops people from accessing services. And then there are supply side barriers in terms of services. You don't have enough people to deliver the interventions. There is not enough policymaker buy-in. Policymakers are not putting money in. So there's demand side barriers as well as supply side barriers, which then leads to this problem of not having the services for people with mental health problems. And from our perspective as researchers, why is this not happening, right? So because as I said, there are evidence-based interventions, but they are not reaching the people. And why do I have 17 years here? I have 17 years here to show you how much difference can happen in 17 years, right? Between 2000 and 2017, this is how much life has changed for all of us. Like, you can imagine that, okay, just to use, because many of you are young people, I'll just use the example of smartphones. You probably don't even know what I'm showing there on the 2000 year. But that's the kind of change that has happened in 17 years. And why am I harking on this 17 years? I'm harping on this 17 years because 17 years is on an average the number of years that are required for research evidence to translate into clinical practice on the ground. So I might generate some research evidence about an intervention today and show in a randomized controlled trials that something works in reducing, let's say, depression or alcohol disorders. But for people to benefit from it to translate from that into policy change, into it being available on the ground to people who need it, it's 17 years, if at all. Because all interventions do not even go through this 17-year journey. So that's the kind of problem that we are dealing with. And there are several reasons why it takes 17 years. I mean, there are things such as time. I mean, you might have healthcare workers, but they don't have time to deliver your interventions. You might start off the intervention, but there's not enough money to keep it sustained. There's stigma which stops people from accessing the services. The effects of an intervention when you kind of test them in a trial, which is a highly controlled environment, and taking them into the reality of the messy world, the effects of it gets diluted. Or healthcare workers, policymakers have competing priorities because mental health is competing with malaria, with tuberculosis, with HIV, with hypertension, with poverty, with education. It's competing with just about everything. So there is competing priorities, red tape, and then at the end of it, just making it available is not enough, right? Just making a service available is not enough. If it is not accessible, if it is not equitable, just because it's there and it's being delivered is not helpful. So there are various other aspects of accessibility that need to be taken care of, which include geographical access, equity, etc. So why have we reached this stage? Why have we reached this stage where, after so many years and with so much evidence, we are still struggling? And one of the reasons we are struggling is because historically we have kept doing the same thing over and over and over and over again in terms of healthcare delivery for mental health problems and expected different results. And what is these things that we have been doing over and over again? These things are broadly around what do we treat? What are the conditions that we treat? Where do we treat? How do we deliver the interventions? And who delivers the interventions? And let me tell you what we have been doing repeatedly for each one of those. So the first one is about what do we treat, right? As you know, we treat diagnostic categories: depression, anxiety disorders, psychotic disorders, obsessive compulsive disorders. We try to put people into nice, neat little diagnostic categories and boxes. The reality of the matter is that in the real world, people with mental health problems do not fit into neat little boxes. People with depression might have a little bit of anxiety. people with obsessive compulsive disorder might have depression. Or if we just look at an examples of, to make a diagnosis of depression, you need to have a set of symptoms that, as defined by the ICD-11, which is a WHO document, American Psychiatric Association's DSM-5, you need to meet a certain number of symptomatic criteria for a certain period of time, after which you can make a diagnosis of depression, which I believe is 14 days. You need to have those symptoms of a certain intensity for 14 days. But this is a artificial threshold, is what I can say, because how is it that someone who has certain number of symptoms with certain intensity for 13 days, and you meet them and say, sorry, you don't have depression, and next day he comes to you and say, sorry, you've got depression today? Doesn't work that way, right? So that's what we have been doing. That's what we have been doing over and over again, trying to kind of get different results. How do we change this? What do we want to do differently in the global mental health space is not to respond to diagnosis, but to respond to distress. Because distress is universal. I'm not interested in whether you meet those 5 symptoms for 14 days. I'm more interested in what distress is it causing you. If it is causing you distress, then I have to respond to it. Whether it's 13 days, whether it's 14 days, whether it's 2 months, whether it's 2 days. Right? So that's moving from diagnostic categories to responding to distress. Reimagining where we deliver these interventions, right? So historically, again, interventions have been delivered within this mental health space in clinics or hospitals. So people requiring this care need to go to meet the clinician from wherever they live. Sometimes very, very long distances, long geographical distances that people have to travel, especially in low resource settings. So reimagining this with global mental health, where we're saying interventions and care needs to be delivered in communities where people live closer to their homes. People shouldn't have to travel long distances to go and find a mental health care professional. Mental health care delivery should happen close to people's homes in their communities where they live. Reimagining who provides this treatment. Again, historically, psychiatrists, psychologists, psychiatric social workers have been trained to deliver this intervention. And the global mental health field has been challenging this paradigm for several years now. What we are saying is that we can use non-specialist health workers using something called as task sharing to deliver frontline, low-intensity psychosocial interventions to people who have mental health problems. And there is immense amount of evidence about that now, where you can use non-specialist health workers. Task sharing is basically a rational redistribution of frontline healthcare tasks to people who are not healthcare workers, who are not experts, who are not specialists. You train them to do certain tasks. And this, from the work that we do, is just some examples of kinds of people that can be trained to deliver psychological interventions. Right? These are some of the counselors that I work with in India and who have been delivering psychological interventions. Now, you might say that this is a very fanciful idea and something that has come from someone's head, and you're saying, yeah, you should be doing this to reduce the treatment gap. I just want to convince you with some examples of work that we have done in India around this and tested this in randomized controlled trials, okay, which are like the most rigorous research designs to test the effectiveness or to test whether an intervention works or not. One example is Manas. Manas was a trial in which we tested an intervention for common mental disorders, which is depression, anxiety, and somatoform conditions, to be delivered by non-specialist health workers. These are people from the community whom we identified and trained to deliver this intervention. We found that compared to usual care, what usually happens in the system in this setting, compared to that, an intervention delivered by non-specialist health worker was superior, significantly superior, in reducing the burden of common mental disorders in terms of prevalence, in reducing suicidal behaviors, and in reducing number of days with disability. This was a randomized controlled trial. Then we thought, this is one kind of a non-specialist health worker delivering an intervention for one kind of a mental health condition, right? And nowhere in the world will a policymaker put in money for one kind of healthcare worker for one condition, right? So we have to demonstrate that these same healthcare workers are able to deliver interventions for different kinds of conditions, right? You don't have a healthcare worker for diabetes only. So in some cases you have, but it's not the best way of using. You don't have one for hypertension. You try to kind of leverage or make the best of the resources. So we trained a different set of healthcare non-specialist health workers to deliver psychological interventions for two conditions, for depression and for drinking problems. Again, tested these in a randomized controlled trials, and I'm showing you only the results of the drinking problems trial, or not of the depression trial. But again, we were able to show that intervention delivered by the non-specialist health worker was superior to enhanced usual care in terms of increasing remission, abstinence, and proportion of days absent, proportion of days in the past 2 weeks when the person did not drink at all. We saw this at 3 months. We saw this sustained at 12 months for a year. And we saw similar positive results, although I'm not showing them to you in terms of graphs, for depression as well. So this same set of healthcare workers, non-specialist healthcare workers, were able to deliver effectively interventions both for depression and for harmful drinking. Another set of piece of work that we did at Sangath in India with looking at perinatal depression. Again, this is work that we did in Rajasthan. These are our non-specialist healthcare workers, ladies from the villages that we worked in rural Rajasthan. But this is what your results you see are from a trial that happened before we took this work to Rajasthan. Effectively, again, showing that the non-specialist health worker delivered intervention called Thinking Healthy program, peer delivered, was efficient and effective in leading to remission at 6 months and recovery at 6 months. Again, another example of a different kind of a condition, but against non-specialist health worker delivered intervention. I just want to touch a little bit on traditional healthcare and leveraging it for mental health care delivery, right? Because there's a lot of work that has happened around it, a lot of work that's happened in Africa around this. I just want to touch on a little bit of some of this that has happened within the space in India. And this is not work that we have done, but I just kind of trying to explore the span of things that one could do for mental health care delivery. So this was in the 90s. So there's this place called Iravaadi in Tamil Nadu, which is in South India, where there is a shrine, a spiritual shrine, and outside that shrine was this place or camp for people with severe mental health problems. So family members would bring them there, and they would be made to stay in the camp, and there would be some kind of spiritual healing that would happen at that dargah. And people with severe mental health problems would be kept chained onto the beds in those camps at night. And one night, the camp caught fire. And many patients who were there in those camps died because they couldn't escape. They were chained to those beds. This was an horrifying tragedy. It served a notice to the nation. And the Supreme Court took notice of this and came down heavily on these kind of camps. Fast forward to 20 years from then, and there's this program in a state on the western coast of India, Gujarat, called Dawa or Dua, where there is a similar kind of a dargah, spiritual shrine, where a caregiver of someone with mental health problems initiated this program. Dawa or Dua, for those who don't know vernacular in India, Dawa means medicine, Dua means blessings. They set up this clinic outside of the dargah, of the spiritual shrine, mental health care, so evidence-based mental health care being delivered. They worked collaboratively with the people in the dargah, the faith healers in the dargah, on this program. So people with mental health problems, family members would take people with mental health problems to the dargah for healing, faith healing. The faith healers would do what they are supposed to do, and then also suggest to the people to take the patient to the clinic outside the dargah. So an example of collaborative working, modern medicine and faith healing. And then they would go to the clinic, and they would get modern evidence-based care. Patient would get better. The faith healer would get the credit, which is all perfectly fine as long as the patient is getting better. And so that's an example. Fast forward to a few years later, and I just remember this story that I told you about Irrawaddy, where these patients died in those camps. Same place now has a modern evidence-based, this picture that you see, modern evidence-based mental health care clinic outside that shrine now. Same model, faith healers working collaboratively with providers of evidence-based mental health care. So that's how far we have come in terms of mental health care delivery. Long way to go still, but that's how far we have come. I've spoken a lot about treatment for mental health problems. What I have not spoken about is prevention and promotion, because that's one end of the spectrum, right? It's not just enough to provide care for people once they have developed mental health problems. It's also important to do things so that we can prevent or delay the onset of mental health problems. And we have to be very creative in doing some of these things. So this is an example of a program that me and my team run called MeWe Sports, which stands for Mental Wellbeing and Sports, where we work with young people in schools using different kinds of sports to teach them or help them develop resilience in terms of various different things, boosting their self-esteem, helping them deal with peer pressure, helping them deal with failures. All of these life skills are taught through sports. So it's not about giving them lectures about this, but using sporting activities to help them learn these skills. No healthcare or mental health care talk today would be complete without talking about technology, because everyone thinks that technology is the answer to all our problems. So I want to kind of talk a little bit about technology. There is growing evidence now around how digital technology can be leveraged for various different functions in mental health care, be it identification of people with mental health problems, be it self-care apps or internet-based self-care websites, be it training of healthcare workers, be it supervision of healthcare workers, be it aids that the healthcare worker can use to help them diagnose and decide on treatment pathways. So there are several different ways in which technology can be leveraged for delivering mental health care or across the spectrum of work that we do in mental health care delivery. Enough evidence at the moment, growing evidence, but we still need to do more. It's not the answer to all our problems, but it can be a supplement to all of the work that we do with human beings in terms of healthcare delivery. But a few things that I would want you to reflect on every time you think that technology can be an answer to all of our problems when it comes to mental health care. So the first thing is, can we trust the numbers that we get around access to technology? Because we hear this whole gung-ho narrative about, everyone has access to smartphones and technology these days, regardless of which country you might be in. You might not have food on your plate or water to drink, clean water to drink, but you will have a smartphone in hand. A lot of that is rhetoric. When we look at the actual numbers, they do not hold up. That's the first thing. Second thing is, you might have a phone, but you might not know how to use some of the features that you need to use to access some of the services that you can for mental health care delivery. There's just this very recent report that's come out from India, which kind of broadly says that I guess only a third of the people who have smartphones do know how to access internet and what was it? Two or three things related to technology. And they can make phone calls, they can read and send messages, but the other features, the literacy is pretty low at the moment, and which is not much different for other parts of the world. Another big issue that we deal with is who owns the phone, right? So in many settings, there might be one single phone which the whole family uses. And who holds the phone is usually the head of the family. And who is the head of the family usually is the man in the family. So there is inequitable access. We know that women with mental health problems in any case have inequitable access to mental health services. But if you're delivering services through technology or through the phone, confidentiality, privacy, who has the phones the increased risk of potentially violence to the women, a lot of things to think about. It's not just about having phones, but who holds the phone in the house, the question. Where is the data going? This is confidential, private information that goes into many of these systems. Who owns this? Who owns this data? Where does this go? What is done with this data? Something for all of us to think about. And finally, evaluation methodology. I mean, this is very important because traditionally, the whole system of developing and testing interventions and then translating them into clinical practice is a very, very long process. And technology does not lend itself, or technology-based interventions do not lend themselves well to this traditional methodology of testing interventions. Because if we were to go through this process, by the time we have finished the process and say that this intervention works, now it's ready for translation, that technology has probably become obsolete. Because technology changes rapidly, right? So it does not lend very well to these long, rigorous methods of. So we have to be figuring out methods which are shorter, but at the same time retain their rigor, because you don't want to put unsafe stuff out there to vulnerable populations. Another thing that I've not spoken about much is I've spoken about the delivery issues, right? All of the things that I've spoken up until now is to reduce the supply side barriers. How do we make these interventions available to people? But the flip side of the coin is the demand side barriers, right? You could make the best interventions available at scale at the community level, closer to people's homes. But if people don't know about these interventions, or people don't believe in these interventions, or there's stigma around these interventions, then people are not going to access it. So we have to be working on reducing those barriers as well in terms of awareness building, psychoeducation, and various other things, some of which includes technology, use of technology as well. But just to kind of say, while I have focused on the supply side, the demand side is equally important for us to kind of work on. And finally, I mean, all of these things that we do in terms of research and generating this evidence and showing what works, all of that at the end of the day is not useful if it does not get to the people at scale. And the only way to get it to people at scale is through the public sector and governments. And the only way that happens is through policy influence. So this is just an example of how some of the work that we have done has influenced policy. For those of you who are not from India, Ayushman Bharat is the government's kind of very ambitious universal healthcare program. And the mental health care guidelines in there reflect some of the work with non-specialist health workers that we have done. That's me on the left. Behind that mask, I'm smiling because I'd gone for a field visit for one of our projects in Gujarat, and I saw the first health and the health and wellness centers which have been set up as a part of this program. I was pretty excited to see it. But you can't see the excitement on his face because of the mask. And then this is another example of work that I'm doing in Goa at the moment called Impress, which is an intervention, the same intervention that I spoke about earlier, where we train non-specialist health workers to deliver harmful drinking intervention and depression care. That was in a research context. In this program, we have now scaled this intervention up across the whole state of Goa in India through the public sector. So this is not programmatic staff now who are paid salaries by the organization to deliver this intervention. These are people from within the health sector. These are different cadres of healthcare workers within the health system of the Directorate of the Health Services who have been trained to deliver this intervention. We have now scaled up this program across the whole state so that every primary healthcare center in Goa now has at the very least one person, in many cases more than one person, who is trained and is delivering psychological intervention for depression to people from the community. And finally, I just want to kind of also reflect on how things have changed in terms of dissemination of knowledge, right? Historically, what has happened in the global south is that we would pick up packages of care that were devised or designed in the global north, in Western countries, quote unquote developed countries, and take them as is to our countries and test them whether they worked. The world is changing. things are now moving in the other direction. This is just one example of work that we have done in India, which is again the depression intervention, which is now being tested in a pilot program in Texas in the US. Another example is the work of one of my colleagues from the London School, Dixon Chibanda Friendship Bench, which was designed, developed, tested in Zimbabwe, which was we took it to New York City, and now there are plans to take it to some parts of the UK. So again, things traveling from the global south to the global north. Lest I communicate to you, or lest you feel that, oh, I'm saying this great things about global mental health and how wonderful it is, I just want to kind of reflect very quickly, in the interest of time, we don't have much time, on some of the critiques of global mental health in this space, right? So one of the critiques is the fact that these mental health problems that we speak about, like depression, anxiety disorders, are just globalization of the Western conceptualization. We have just kind of taken these Western constructs and taken those to our countries, and they reflect colonial power structures in terms of pathologizing or medicalizing human suffering. There are critiques about the treatment gap, as that I spoke about, that only 1 to 3 people receive care. There's a critique of that it's so focused on treatments and not on the other things that happen around mental health problems. The actual larger care, the social care. So kind of trying to reduce that, the physical health problems that happen with mental health problems. So just focusing on treatment as a concept is a problem. There are questions around who decides what evidence is. Is people sitting in the West, or people like me who are based in Western institutions, then deciding what is the evidence and what needs to be scaled up? There are critiques around the limited involvement of people with lived experience with mental health problems in designing these programs and interventions. Why is it that quote unquote experts like me and others decide how do we provide care for people with mental health problems? And then there is the very kind of well-written, spoken about, controversial role of pharmacological industry in terms of influencing some of these narratives. I'll have just 2 more slides to go to, and I just want to kind of reflect on this bit by telling you a story. Around 10 years or so ago, we were running a program in a place in India called Vidarbha, which is, for those who are from India will know, is infamous for farmer suicides. And we set up a program there called Vishram, the focus of which was to try to reduce the farmer suicides by reducing depression and drinking problems. So we scaled up program of these interventions for depression and harmful drinking across many villages in Vidarbha, and we ran an implementation program. And the program ended. We had this big event in one of the bigger towns of that region for the dissemination of the program. And we called several beneficiaries of the program to come and speak about the program and give some testimonials about their experience of the program. And there was this gentleman, who was a farmer, who was a beneficiary of the program, who came on stage and spoke about his experiences. And I continue to talk about this gentleman because he stayed with me. He came and spoke about how wonderful the program was, and he said how he was when he was depressed, how the treatment, the counseling that was provided by the non-specialist health worker helped him, and his depression went away. And then he said, all of the things that I was experiencing in terms of the depression have now gone away. I don't feel low. I don't feel sad anymore. I can sleep well at night. I have a good appetite. But you know what? One thing has not changed. I still don't know how I'll pay off my loan. I still don't know how I'm going to have next meal on my plate. I still don't know how I will get my children educated. So to me, this was an example of how we were focusing on the end problem, which was the depression, without focusing on the social determinants of mental health problem. Because a lot of mental health problems is associated with a range of different social determinants, be it poverty, be it education, be it neighborhoods, unsafe neighborhoods, be it access to safe drinking water, be it food security. All of these things are associated with mental health problems. And in the absence of us doing something about these social determinants, we are only working on the tip of the iceberg in terms of treating people who eventually go on to develop mental health problems. So with that, leaving you with that kind of comment about social determinants, I just want to end by thinking through what we should be doing now, having kind of established all of this kind of high level global mental health space and what we have been doing. First thing that we have to be doing is it's time for action. It's no longer about we need to know what works. We need to know what kind of health systems we need to put in place. We need more evidence about interventions. We know all of that now. It's time to do something to make these things available at scale. It's time for action. Secondly, mental health and mental health care is not the domain only of psychiatrists and psychologists and psychiatric social workers. It's everybody's business. Teachers, parents, legal system, everyone's business. As someone wise said, mental health is too precious to be left in the hands of psychiatrists. It's everyone's business. What we do, however, needs to be evidence-based. We can't repeat what we were doing before. What we do needs to be evidence-based, but very importantly, that evidence-based has to be supported by contextual relevance and cultural relevance. We can't just import things from anywhere else and kind of import it. It has to be suited for your context and culture. We need to be thinking how we can strategically leverage different platforms of care to provide mental health services. Right? And what do I mean by platforms of care? We need to integrate mental health services into clinics that provide care for diabetes. We need to integrate mental health care into platforms of care that provide services for HIV, for tuberculosis, because there's a huge comorbidity of these physical health problems with this, or services that provide care for women who experience intimate partner violence or domestic violence. Need to integrate mental health care into those services. We need to be focusing on social determinants. I don't need to stress on this base. I mean, like I've kind of talked about this in my previous slide quite a lot. We need to be focusing not just on treatment, but also on social determinants. We need to be focusing not just on treatment when people develop mental health problems, but on prevention. How do we prevent it? How do we delay onset of mental health problems? How do we stop mental health problems from happening? And finally, we need to be working on convincing and influencing policymakers to convert some of these evidence into policies, because that is the only way in which we can make some of these evidence-based interventions available at scale to people who need it. I think with that, I end my talk. I look